Welcome to Neurology ABIM Review. Carotid artery dissection can occur after trauma and typically presents with unilateral head and neck pain along with transient vision loss. Patients may have ipsilateral partial Horner syndrome, which includes ptosis and meiosis without anhidrosis. Signs of cerebral ischemia can develop because blood enters between the layers of the arterial wall, creating a clot that can cause ischemic stroke. The diagnosis is confirmed with CT angiography. Treatment may involve thrombolytics if the patient presents within 4.5 hours of symptom onset, along with aspirin and sometimes anticoagulation. Treatment of carotid artery stenosis depends on symptoms and degree of stenosis. If 100% stenosis already, then do medical therapy alone with antiplatelet agent given collateral might have happened. If acute stroke, then do DAPT without any procedure given risk of bleeding. Now, if stenosis is more than 70%, patient needs carotid endarterectomy. In symptomatic patients with history of TIA, stroke, this must be done within 14 days. In people with 50 to 69% stenosis, people who had TIA or stroke in past should get carotid endarterectomy. Rest all managed with antiplatelet agent. Obviously, after stenting in carotid artery, we should do dual antiplatelet for 1 to 3 months followed by single agent after that. Post-concussion syndrome can occur hours to days after any severity of traumatic brain injury. Symptoms include headache, confusion, amnesia, difficulty concentrating, multitasking, vertigo, mood alteration, sleep disturbance, anxiety. Greater than most patients improve within weeks to 3 months. Treatment is symptomatic, analgesics, sleep hygiene, reassurance. No need to do EEG, repeat MRIs just for above symptoms. Idiopathic intracranial hypertension occurs in young obese women and can be associated with vitamin A, tetracyclines, growth hormone, isotretinoin. Symptoms include chronic hollow cranial, pulsatile headache. Worse with lying flat, improved with sitting up and visual disturbances due to cranial nerve 6 and tinnitus. Key sign is papilledema. Right pointing arrow can lead to rapid vision loss. Diagnosis: with ocular exam for papilledema, MRI plus or minus MRV to exclude secondary causes. Lumbar puncture with opening pressure greater than 250 mm hydrogen oxide, CSF normal. Treatment includes weight loss, acetazolamide plus or minus furosemide, corticosteroids, serial LPs if awaiting surgery. Surgical option include optic nerve sheath fenestration or CSF shunt for progressive visual loss. Recurrent migraines, more than 4 per month, need prevention. Topiramate is good for young obese and causes weight loss. It should be avoided in kidney stones, pregnancy. Propranolol needs to be avoided in asthma, smokers and people with age more than 60 years. Pregnancy migraine treatment include: first line is acetaminophen. If inadequate response, then NSAIDs. Only in second trimester, opioids, antiemetics are used. Migraine with brain stem aura is occipital HEACHACHE, which might have typical migraine features but has basilar aura symptoms, must have 2 out of these: vertigo, tinnitus, hypoacusis. Diplopia, B.L. visual symptoms. Dysarthria, ataxic speech, gait, impaired conscious. Diagnostic workup includes MRI plus MRA brain to rule out stroke in this case. Management with antiemetics with NSAIDs. Verapamil is used for prevention. Greater than triptans, ergotamine, beta blockers are contraindicated. Migraines can turn into medication overuse headaches, example with ibuprofen use. These can have photophobia. Management with discontinuation of ibuprofen, short steroid taper and topiramate use. Both paroxysmal hemicrania and cluster headache have autonomic features with lacrimation, nasal congestion, ptosis and meiosis. Paroxysmal hemicrania (PH) is petite, meaning short attacks of 2 to 30 minutes which are persistent, meaning more than 5 in a day, and has perfect response to indomethacin but can be precipitated with Tylenol use. Whereas cluster headache is clock-like timing, meaning same time daily. Present in caveman, more in males, and catalyzed by alcohol. Cluster headache treated with oxygen and sumatriptan, whereas verapamil for prevention. Sciatica presents with pain on straight leg raise test. Management includes NSAIDs plus light exercise. We have no need for MRI and no physical therapy needed. Carpal tunnel syndrome surgical treatment is needed for severe symptoms, motor weakness, atrophy, axonal injury, or failure of conservative therapy. Restless leg syndrome treatment includes limiting caffeine and alcohol with moderate regular exercise. Medications management includes supplemental iron, if ferritin less than 75, mild intermittent symptoms treated with carbidopa-levodopa as needed. Frequent, daily symptoms managed with gabapentin, pregabalin. Nowadays, ropinirole and pramipexole not recommended given paradoxical worsening in long-term use. Parkinson treatment summary includes levodopa, carbidopa for severe or patients greater than 65 years of age. Dopamine agonists are used for mild-moderate disease and age less than 65. Anticholinergics needed for tremor only, age less than 70 and no significant akinesia, gait issues. Early Parkinson disease may present with non-motor symptoms, REM sleep behavior disorder, hypersomnia, anosmia, mood changes, constipation, before motor signs appear. Phenytoin toxicity presents with dose or level-dependent toxicity. Early presence with nystagmus, horizontal, ataxia, dysarthria. Moderate with slurred speech, diplopia, lethargy, confusion. Severe with coma, seizures, hypotension, cardiac arrhythmias. Hypoalbuminemia and uremia can cause right-pointing arrow toxicity at therapeutic levels given bound phenytoin. Treatment is supportive, using activated charcoal if recent ingestion. Treat seizures with benzodiazepines. Hemodialysis rarely needed, given drug is highly protein-bound. Valproic acid may cause hyperammonemic encephalopathy. Check ammonia and drug levels, stop drug, start lactulose and consider L-carnitine. A patient came in with nausea, either migraine-related or other cause-related greater than, and metoclopramide was given. He then developed sustained contraction of posterior neck muscles. This is acute dystonia. Treatment involves Benadryl and benztropine. If concerned for brain dead by clinical exam, do apnea test, then we do ancillary test if apnea test was inconclusive. Paraneoplastic cerebellar degeneration has subacute cerebellar symptoms, often precede cancer diagnosis, lung, gynecologic, breast, by years. Confirm with antibodies, anti-Yo, anti-Hu, anti-Re. Acute neuritis from herpes zoster right-pointing arrow treat with traditional oral analgesics. Postherpetic neuralgia. Pain lasting months after rash. Right-pointing arrow treat with tricyclic antidepressants, gabapentin, or pregabalin. Antivirals right-pointing arrow only recommended if patient presents within 72 hours of symptom onset. In cancer patient treated with radiation in past, comes in with pain, we need to differentiate radiation-induced versus cancer progression pain. In cancer invasion, patients have severe early pain, lower plexus, Horner syndrome. Whereas radiation injury has late pain, upper plexus, paresthesias and weakness. Thank you.